So we're going to talk about Chapter 9. Chapter 9 is going to really focus on therapeutic communication. Communication takes on a new emphasis with nursing care. Just as personal relationships are different from therapeutic relationships, basic communication is different from patient-centered, goal-directed, and scientifically based therapeutic communication. So let's get started here. Therapeutic communication is crucial to the formation of a patient-centered therapeutic relationship. When we say patient-centered, that refers to the patient as a full partner in care, whose values, preferences, and needs are respected. Therapeutic communication is a professional ability that you learn and practice. But with psychiatric nursing, communication again takes on a whole new emphasis. Will saying the wrong thing be harmful to the patient? Making mistakes helps us to find more useful and effective ways of helping individuals reach their goals. So even if you make a mistake in communication, or if you say the wrong thing, there's very little chance that that comment will be harmful. What are some of the benefits of therapeutic communication? This can include the patient feeling safer and protected, being more satisfied with the care, having increased recovery rates, and improved adherence to treatment. Poor communication can create serious problems such as death, malpractice claims, and even increased malpractice costs. Communication is an interactive process between two or more persons that interact with each other. The transactional model is systematic and useful for psychiatric nurses. The communicator are the senders and receivers. They are both considered to be communicators, which makes this role very fluid. The message is the information sent to another. The clearer the message, the better it will be received. The message can be through a variety of channels, including auditory, visual, tactile, olfactory, or a combination of these. The person receiving the message then interprets the message and responds to the sender to give feedback. When we think about encoding and decoding, while interacting, individuals encode or develop the message and send to the other, and then decode, determine the meaning messages received from the other. The context frames and influences our interaction, and that can include social context, relational context, or even cultural context. Environmental noises can definitely disturb the message flow and serve as a barrier to interaction. Some of those environmental noises can include physical noises, which is what our loud noises, our monitors, all the beepings, all of that. Or it could be physiological. Those might be those biological factors, such as an illness. Peplau also encouraged non-directive listening. This allows nurses to provide reflective and non-judgmental feedback, and thereby enables patients to clarify their thoughts. Clarity ensures that the meaning of the message is accurately understood by both parties. Continuity, on the other hand, promotes connections among ideas, feelings, events, and themes. So what are some of the factors that can affect communication? Personal factors can play a role. Could include difficulty with communication, language barriers, and even cognitive factors. Depression may result in slow thinking and difficulty communicating. Anxiety could cause a lack of concentration, and mania could create an inability to focus. Language barriers reduce the flow of normal communication, and cognitive factors have to be considered when we're providing education to our families or our patients. Environmental factors also affect communication. Think about all the background noise, the lack of privacy, the uncomfortable accommodations within the healthcare setting that can really reduce the flow of good communication. And the last factor we can talk about is relationship. This can also affect communication. When there's a difference in status or power, such as between a nurse and a patient, the relationship is characterized by inequality, meaning one participant has more control. This inequality could decrease as the patient recovers. Verbal communication consists of the words a person speaks. Words are a symbol for emotions and mental images. When we speak, we communicate beliefs and values, perceptions and meanings, which can convey interest and understanding, insult and judgment, clear or conflicting messages, or honest or distorted feelings. Nurses also need to be very aware of how they communicate non-verbally. Nurses should also assess the client's nonverbal communication. Nonverbal communication may be sending the real message. So we need to watch our tone of voice, emphasis on certain words, and manner in which a person paces speech are both considered nonverbal communication. Physical appearance. You can see in the picture there, if you have a crowd in front of you looking like that, you're probably getting a lot of important information from that. Facial expressions are extremely important in terms of nonverbal communication. The eyes and the mouth seem to hold the biggest clues on how someone is really feeling. Body posture, amount of eye contact, and hand gestures are all key nonverbal communicators. We primarily think of communication in terms of what is said, but indications of nonverbal cues are a better predictor of attitude and feeling more than words are. Messages can appear to be one thing when in fact they are another. People are often less aware of their nonverbal messages and behaviors. Verbal messages can be called the content, while the nonverbal behavior is the process. And when we think about double bind messages, these are mutually contradictory messages, usually given by a person in power. Some examples of double bind messages might be, you must go to sleep. Well, we know we can't force sleep, so that's a contradictory message. You must be motivated. Motivation is complex, and you simply cannot command it. You're going to soccer practice, and you're going to enjoy it. How about be spontaneous? It would be artificial if it's being commanded. And then don't be scared is the last example I have. Fear can't be commanded away. So each of those are examples of that double bind message. Communication skills for nurses include therapeutic communication skills, clarifying techniques, and questions. Some of these. Once you've established a therapeutic relationship, you and your patient can begin identifying specific needs and problems. Strong communication skills facilitate work, and these skills are called therapeutic communication techniques. Useful techniques include the use of silence. This can feel very awkward and uncomfortable. Silence is not the absence of communication, but a specific channel for transmitting and receiving messages. Silence may also provide a moment of reflection for the patient and the nurse. Silence is not always therapeutic, though. Prolonged and frequent silence can actually hinder an interview that may require verbal articulation. This could make the patient feel uncomfortable and withhold information. Active listening is another technique that we can think about. Nurses must have full concentration, understanding, responding, and remembering of what the patient is saying verbally and non-verbally. The nurse is able to hear, observe, and understand what the client communicates and to provide feedback. Remember to listen with empathy. The use of clarifying techniques also helps verify nurses' interpretation of the patient's messages. So, what are some clarifying techniques? Paraphrasing. This is when you restate the basic content of a patient's message differently and in a few words. If you use restating, this differs from paraphrasing in that it involves repeating the same keywords the patient has just spoken. Reflecting is a means of assisting patients to better understand their own thoughts and feelings. This may take the form of simple questions or statements. And the last clarifying technique there is exploring. This allows the nurse to examine important ideas, experiences, or relationships more fully. Statements for exploring may start with tell me, or describe, or give me an example. The last technique is question. So asking questions and eliciting that patient's response. Open-ended questions encourage patients to share information about experiences, perceptions, or responses to situations. These questions don't put the patient on the defense, and they can help the nurse obtain information. Close-ended questions should really be used sparingly and will just elicit that yes or no response. This type of question is used usually during that initial assessment of your patient to determine very specific results. The projective questions typically start with what if to help patients articulate, explore, and identify thoughts, feelings, and behaviors they might have in certain situations. And then the miracle question is a goal-setting question that helps patients to see what the future would look like if their problem went away. This can identify goals that the patient may be motivated to pursue. What are some barriers to effective communication? Non-therapeutic communication techniques can also include excessive questioning. So we're asking irrelevant personal questions, or we're firing questions off really rapidly. This may make the client feel like they are being interrogated. Giving approval or disapproval. So praise and approval in a nurse-patient relationship can get very complex. Patients in a vulnerable position may misinterpret the value of the comment. Giving advice is non-therapeutic. It interferes with the patient's ability to make personal decisions. And asking the why questions. This demands an explanation and implies wrongdoing. These why questions imply criticism. Why did you go to that party last night? Right? That shows criticism. It shows judgment. It is much more useful to ask what is happening versus why it's happening. These non-therapeutic communication techniques can impede or shut down our nurse-patient interactions. When we think about cultural considerations, communicating across cultures does pose many challenges for healthcare workers. Several areas of difficulty for nurses in interpreting verbal and nonverbal messages from patients can differ from culture to culture. And some of these might include communication style. In some cultures, expression of positive or negative emotions is a private affair, and open expression of them is considered to be bad taste and possibly a weakness. When we think about eye contact, cultural norms dictate a person's comfort or lack of comfort with direct eye contact. Therefore, do not use the amount of eye contact to assess attentiveness, judge truthfulness, or make assumptions on the degree of engagement one has with a patient. Touch may be seen as a healing and supportive, but it also may be experienced as patronizing, intrusive, aggressive, or even sexually inviting in other cultures. We all need a frame of reference to help us function in our world. The trick is really to understand that other people use many other frames of references to help function in the world as well. So understanding and acknowledging these viewpoints go a long way towards minimizing personal distortions in our listening. So how do we prepare for a clinical interview with the patient? Let the patient set the pace of the interview, no matter how slow or halting the progress. Effective communication can take place anywhere. However, finding a location that makes the patient feel safe will enhance their security and is important for that therapeutic relationship. The setting should be arranged so that the chairs elicit a conversation that is comfortable and non-threatening. Some key points with our arrangement of seats can be face-to-face with a table in between, face-to-face with no table, at an angle with a table in between, or at an angle with no table. Some people believe that a face-to-face with a table suggests a power differential and that the desk serves as a barrier. However, face-to-face discussion does facilitate the best reading of our nonverbals. Introductions usually happen in the orientation phase, introducing themselves, introducing yourself, what's the purpose of the meeting, how long is it going to go, what's the meeting going to be about, all of those things come in that introductions. And then once the introductions are completed, then you can initiate that interview by asking those really good open-ended questions. So what are some tactics that we do need to avoid? We definitely don't want to argue, minimize, or challenge our patients. We don't want to ever give false reassurance, interpret or speculate, probe into sensitive areas that the patient clearly doesn't want to talk about, trying to sell the patient on accepting treatments, joining in on attacking the patient, or if the patient is launching attacks on others. We don't want to join into that as either. And then participating in criticisms of other staff members. Behaviors that support counseling. So we talked a little bit about those attending behaviors. That means that kinesthetic communication is a type of nonverbal communication made by body movement. Facial expressions, body posture, and gestures are all types of that kinesthetic type of communication. Vocal quality, also called paralanguage, refers to the qualities of speech that do not involve words. And the last one is proxemics. That's the study of personal space. So categorized distances include intimate distance. So within the United States, that's about 0 to 18 inches. Personal distance, which is about 18 inches to 4 feet. Social distance, we should be familiar with our pandemic, 4 to 12 feet. And then public distance is 12 feet or further. And that concludes chapter 9. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.